to present here and for suggesting this topic. I'm going to share my slides. Are my slides visible?
Yes, you are visible.
Yeah. So good evening to all. My topic for today is microhematuria. Yeah. So microhematuria is defined by the American Urology Association as more than or equal to 3 RBCs in the urine per high power field. The prevalence of microhematuria in adults ranges from 2 to 31%. It can be associated with a glomerular cause or a urological cause. A urological malignancy is found in 10% cases of microhematuria, especially in older individuals. Dipstick is the basic test to look for blood in urine. It uses peroxidase-like activity of hemoglobin to effect a color change. False positives can be seen in semen contamination, alkaline urine, hemoglobinuria, and myoglobinuria. False negatives are almost absent, though theoretically, consumption of large amounts of vitamin C may cause false negatives, but this is hardly of any clinical relevance. If we find a positive dipstick, it is unlikely that it is a false. If you don't, it is unlikely that you might find a false negative dipstick. So, steps for urinalysis. So second mystery morning urine sample should be collected in disposable containers. Sample handling and analysis should be done within 2 hours from collection. A 10 ml of aliquot of urine is centrifuged at 2000 RPMs for about 10 minutes. The supernatant is discarded and resuspend the sediment. And then examination is done by putting a cover slip over it and examining it under 100x and 400x magnification, preferably by a phase contrast microscope. So light microscopy, automated blood cell counting, and automated urine flow cytometry are also methods for evaluating urine sediment. Right stain can distinguish dysmorphic RBCs from isomorphic RBCs. Now, what are isomorphic and dysmorphic RBCs? So RBCs in the urine can appear isomorphic or dysmorphic. Isomorphic RBCs are biconcave and they are about 6 to 8 microns in size. These can appear crenated in hypertonic urine and can appear spherical or ghost cell-like in hypotonic urine. And then there are dysmorphic forms of RBCs. The presence of dysmorphic RBCs tell us that the source of hematuria is glomerular. Now, before we go on further, let's come to a poll. I invite Binu sir to take on the poll question.
Yeah, this question is basically commonly asked for our exams. So this is actually, it has to be rephrased a little bit. After an episode of acute glomerulitis, that is after a post-streptococcal glomerulitis, if the glomerular poses beyond a particular time, you would consider kidney biopsy. So in which of these conditions could you consider kidney biopsy? 1, up to 4 weeks, 8 weeks, 12 weeks, and 24 weeks. Can we have the poll? Yes, I think we can see the results. Can we have the results? Yeah, majority of them feels that we should biopsy after 12 weeks. This is a common question for all of us in our DM exams. So Dr. Srijit is here. He is an examiner for most of us here. So what are your comments on this particular aspect?
So the microhematuria as well as some amount of proteinuria can take a long time after PIGN, especially in the adults. In children, the microhematuria can resolve earlier, but in a proportion it can persist longer. But when it persists longer, I think we have to be more careful because earlier days, I think we used to miss a lot of C3GN, assuming that they were all PIGN. So I think that is the most important reason. You can do additional tests also. For example, we will usually do a complement levels to know whether there is any persistent hypocomplementemia. But I think it's very important, especially in adults as well as in young people, to not to completely ignore follow-up. If there's persistent microhematuria, I think we need to be more careful, because sometimes it is, to my mind, very difficult to distinguish between an acute episode of IRGN from a C3GN. Yeah, that's what I would say. If it is persisting, we need to be more alert and probably evaluate more. And if we had not done biopsy earlier, which is possible, when we are reasonably sure about the diagnosis, probably we should do a biopsy with an IF and then probably check for persistent hypocomplementemia. It can be other things also. For example, microhematuria can be from IgA nephropathy. Yeah, so I think it's important not to ignore and to have follow-up evaluation after say 3 months or so.
Thank you,
Hope that
Dr.
makes.
Srijit. So I think after an episode of acute post-infectious GN, you would consider biopsy at the end of 12 weeks if there is persistent microscopic hematuria.
Yeah, if it is persisting, if we have not done biopsy, our threshold for biopsy is pretty low. So most of them do get biopsy at an earlier stage. But if we have not, which happens in younger people, if there's a prompt resolution, if it is persisting, yes, I would do a biopsy. I would do more evaluation, primarily to rule out C3GN. Yes.
Yeah. Okay. Thank you. Anybody else? Dr. Martin, what do you think? You're there.
Yes, sir. I also completely agree with what Srijit sir told. And on the other hand, my decision to biopsy or not doesn't even depend on the persistence of hematuria. Hematuria can be there for long periods of time in patients with glomerulonephritis. So I feel the other parameters should come in, like the C3, how the C3 is coming. Initially it was low, now it has come back to normal. The exotemia, which was present earlier, now it has settled. All symptomatologically, the patient is improving. Then I may not consider biopsy, but otherwise, definitely I'll go for biopsy if the microscopic hematuria is persisting.
Thank you, Dr. Martin. I think the point is it should not be ignored. It should be, one should consider biopsy if it is persisting, as Dr. Srijit said, could be a C3 glomerulonephritis as well. Go on, Dr. Jason.
Yeah. So recommendations for urinalysis. Phase contrast microscopy is regarded as the best method for assessing dysmorphic RPCs or acanthocytes. But in the absence of a phase contrast microscope, bright field microscopy can also be used. Now, what are the precautions you should take while examining a urine sample? So avoid strenuous exercise before giving urinary sample. Do not examine urine during menstruation in females. Catheterized samples of urine are unreliable. If dipstick is positive for blood, immediate microscopy of a fresh urine sediment is the best method. Now, hematuria by urine sediment microscopy. When 40% of or more of RBCs are dysmorphic, you can conclude that the origin of hematuria is glomerular. And then there are acanthocytes, which are a subtype of dysmorphic erythrocytes. If you see 5% or more of acanthocytes, again, the origin of hematuria is glomerular, and these are highly specific for glomerular hematuria. Now here on the left side, you can see acanthocytes under phase contrast microscopy, which are dark and circled as seen under a phase contrast microscope. The normal ones are the circular white ones. The circular white ones are the isomorphic RBCs, whereas the dark ones are the acanthocytes. The phase contrast microscope, you can see here on the right side, is a modification of a compound microscope. It contains all the components of a compound microscope in addition to an annular ring and a face plate. So George sir told us about Dr. Birch and Fairley, who taught us about the importance of dysmorphic RBCs. So this is Dr. Fritz Cernik. He is a physicist who invented the phase contrast microscope, which shows us the presence of dysmorphic RBCs better. Now, let's see how these dysmorphic RBCs are formed. Glomerular diseases result in damage of basement membrane and podocytes, and it causes these RBCs to move into the Bowman space. As these RBCs pass through the damaged glomerular basement membrane, there are several osmotic and physical forces which alter the shape of these RBCs and causes a dysmorphic appearance. In the process, they can have slight deformation of membrane when subjected to osmolar shifts, forming blephs. And these blephs give a picture of acanthocytes to these dysmorphic RBCs. It has to be kept in mind that there are certain mimickers of RBCs in the urine, like yeast, spermatozoa, fat droplets, etc. Let's understand the approach to hematuria better with a clinical case. So a 25-year-old asymptomatic woman is referred by her primary care physician after routine urinalysis during a pre-employment checkup, which reveals persistent microscopic hematuria. She has had 3 consecutive urinalyses over 2 months, showing 8 to 15 RBCs per high power field with no visible blood. So there is one point of importance here which has to be told. So whenever there is isolated hematuria, it is necessary that we repeat urinalysis after 6 weeks, as it was done in this case. She denies flank pain, dysuria, frequency, urgency, edema, or any episode of dark urine. There is no history of recent infection, trauma, vigorous exercise, or NSAID use. She's otherwise healthy with normal menstrual cycles and no gynecological complaints. Again, it's necessary to make sure that the patient is not menstruating, as I mentioned before, and rule out all gynecological causes of hematuria. So how do we approach to a case of hematuria as seen in this scenario? So hematuria can be microscopic or gross. We move to the microscopic causes. So if you have an access to phase contrast microscopy, you can look for dysmorphic RBCs, which will suggest a glomerular origin for hematuria. Look for associated proteinuria, hypertension, see if the renal function is deranged or not. All these can give a clue to the cause for the hematuria. Sometimes you may find just isolated microhematuria, as I described in the case scenario. So what is isolated microhematuria? Isolated microhematuria is defined as microscopic hematuria in midstream urine sample on more than one occasion and unrelated to exercise, trauma, or menstruation, in the absence of proteinuria, in the absence of hypertension or kidney impairment at presentation. So this isolated hematuria was previously considered a benign condition, but now studies point out that it may not be as benign after all. So whenever we see a case of isolated hematuria, certain differentials should always be kept at the back of the mind, like IgA nephropathy, especially the early stage or mild IgA nephropathy, and Alport spectrum disorders, about which I will speak in due course. In these conditions, hematuria dominates the clinical picture. So in cases like my IgA nephropathy, whenever you see mild hematuria, it mostly impairs that the hematuria might just seem to come first. And these patients could, in the long run, go on to develop proteinuria and renal insufficiency. We know the 4-hit hypothesis leading to the formation of IgG anti-galactose deficient IgA1 immune complexes. So these damage the glomerular capillaries, resulting in the passage of RBCs into the urinary space, finally developing hematuria. Another situation where you can have isolated microhematuria is collagen 4 or Alport spectrum disorders. So during development, what happens is the glomerular basement membrane lattice has alpha-1, alpha-1, alpha-2 structure. So this changes to alpha-3, alpha-4, alpha-5 protomers at maturity in healthy adults. And these are encoded by the COL4, A3, A4, and A5 genes. And these genes with the alpha-3, 4, 5 structure provides mechanical strength and filtration properties to the GBM. So coming back to our case, on probing the family history, there was history of hematuria in mother and younger sister too. But neither has pursued further evaluation, and both have normal kidney function. So this lady underwent a renal biopsy. This was what the biopsy showed in electron microscopy. There was diffuse uniform thinning of glomerular basement membrane, less than 250 nanometers on electron microscopy, with normal light microscopy and immunofluorescence. And this was suggestive of thin basement membrane disease. Before advancing further, we go on to the next poll. Binu sir.
Yes, electron microscopy is widely available these days, and we should be aware of what situation we would want exactly an electron microscopy. So an electron microscopy will be ordered in a patient with persistent microscopic hematuria if the light microscopy is normal, if there is negative, IF negative mesangial deposits if there is a family history of renal disease or if there are extra abnormalities not noticed. So it could be any of these. So let's get the poll and opinion regarding this.
That's a difficult choice to make.
Yes, Srijit, what are your comments there? Electron microscopy is routinely done these very often. So what should be specifically
I don't
looked
know whether our comments will influence the answering. People are trying to answer the poll, I suppose.
Yes. But then these are all situations where you would definitely ask for a electron microscopy, I believe.
Yeah, I would say with EM, the recognition of these collagen 4 disorders have significantly increased. So unless it is a convincing IgA, for example, if you see there are extrarenal anomalies, for example, the patient has Lindy corners or hearing impairment, that will be an indication for collagen 4 disease, family history of kidney disease. So there is an overlap between that. That's why I was saying it is complicated. So unless it is a biopsy, it is very clear IgA nephropathy, I would definitely do before biopsy itself. If we are planning biopsy for isolated hematuria or asymptomatic low levels of proteinuria, we invariably plan electron microscopy. So main reason is to pick up the thickness of GBM. If the light microscopy and IF is showing a clear IgA, which is possible, then electron microscopy, I would say, is not necessary to confirm IgA. So all other situations, usually by default, we will be planning EM, unless the patient is unable to afford, but we usually try to do. Because I think if by doing that, I think the rate of pickup of the collagen 4 disorders, even when extrarenal manifestations are not there, is significant. I will not say it is highly frequent, but it is quite significant. So I would probably do for everyone when I'm biopsying for microhematuria, unless I know that there is infantile hematuria and IgA is already there, then maybe I may not do. Otherwise, I think I will always do EM.
So the point is clear. If there is IgA deposits, you would stop with it. If not, you go and get an EM done.
Provided sometimes the family history can confuse. We have had consanguinity is quite common in this part of the country, so we have had familial IgAs also. If family history is there, we will still do because we have found overlap between Alport syndrome and IgA. I had presented it in one online forum also. So it's very rare, but then if family history is there, even if you find IgA, I would still go ahead and do at least genetic testing, if not EM. Yeah.
I think you have a short comment, Dr. Satish.
Yeah, I just wanted to add one comment to this. If person microscopy hematuria, I would probably do a genetic study first before going for a biopsy, because more likely to be a genetically mediated disease. And like Dr. Sage was saying, familial IgA is many times associated with collagen 4 abnormalities. So you can see on the EM also, you can find basement membrane abnormalities, and on the genetic study also you can see. So probably there's no overlap. So this familiarity may be because of the associated basement membrane abnormalities. So there is a lot of overlap between genetic and acquired disorders also. So these are all coming out nowadays. Thank you.
Okay, Jason, continue, Jason.
I think it's a very important point he made that we need to strongly consider genetic testing in this situation.
Yeah, we'll come to that.
Yeah, so sometimes in spite of the normal switch of alpha 1, 1, 2 to alpha 3, 4, 5, there still be variants in the genes resulting in basement membrane formation. That causes thin basement membrane nephropathy. So this can be familial or sporadic. So as you see in this electron microscopy image, there can be diffuse thinning of the lamina densa layer. So as per WHO criteria, adults, regardless of gender, if the basement membrane thickness is less than 250 nanometers, and in children below 11 years, if it is less than 180 nanometers, you can call it thin basement membrane nephropathy. So usually the prognosis is benign, but there is slight increased risk of CKD in carriers of Alport syndrome. And sometimes many of these patients can be carriers of autosomal recessive Alport syndrome too. So let's analyze the spectrum of disorders involving collagen 4. So defects in alpha 3, 4, 5 network leads to glomerular basement membrane abnormalities, resulting in a clinical spectrum ranging from benign isolated microscopic hematuria to progressive kidney failure with extrarenal involvement. So persistent hematuria is a common presentation in these conditions. The milder and less severe forms include benign familial hematuria and thin basement membrane nephropathy, often benign isolated hematuria. Sometimes these can involve to proteinuria, hypertension, ESRD, declining kidney functions, and even ESRD. So as we move to the end of the spectrum, there are severe forms like Alport syndrome. The severe forms often have extrarenal manifestations like sensory neural hearing loss, ocular abnormalities like lenticonus, retinal flex, etc. Now, this is where the importance of looking for extrarenal features, taking a family history, looking for genetic testing, etc. becomes important. So whenever you see a case of diffuse GBM thinning electron microscopy, there is a role for genetic testing. So genetic testing can be diagnostic or prognostic. So it should be done in young CKD cases, those with multi-system involvement or extrarenal involvement. It should be done if there is a history of consanguinity in the family, conditions amenable to a targeted treatment like Fabry's where you need to supplement an enzyme, or ADPKD where you can slow disease progression using tolvaptan, and also it should be done in a case where you can plan the family planning. And it should also be done. It can also be done as an alternative to kidney biopsy in patients at high risk of biopsy-related complications, or when there is a high pretest probability of finding a genetic variant based on family or clinical history. Now, genetic testing also has a prognostic role as in pro-PKD scoring of ADPKD, where you know that the truncating mutations have a higher pro-PKD score and has worse prognosis. It also guides management of diseases. If, for example, if you find a genetic cause for certain diseases like FSGS, you can avoid unnecessary immunosuppression. It also helps in choosing related donors for renal transplant, where if you find an individual is at risk for a certain disease, you can avoid that donor. So this brings to my mind a particular case while I was in Bangalore. So a 20-year-old female presented with severe renal failure requiring dialysis. So her kidneys were shrunken, and so biopsy was not an option. We transplanted her with mother as a donor. There is no family history of kidney disease. So about a year later, during a routine follow-up, she mentioned that her younger brother developed hearing loss. So her younger brother was around 12 years of age at that time. So this prompted me to assess the younger brother's renal function. He had hematuria, but then his creatinine was normal. So finally, we did a genetic testing on the brother and also the donor mother. So the brother was found to be X-linked recessive Alport syndrome, and her mother was found to have autosomal dominant Alports. The mother is fine till date. Also, she did not have any hematuria on pre-transplant evaluation. We did not trust the recipient because of financial issues. Probably she might have had an autosomal recessive Alports, which have led to a renal failure. So this girl was around 20 years of age. Maybe if we had known, if we had done a genetic testing prior to transplant, probably we could have avoided the donor mother, because patients with autosomal dominant Alports can develop end-stage kidney failure at later ages. Now we come to a poll. I request Vinisar to take on.
When you consider genetic test in a patient with microhematuria, which would you prefer as the most appropriate? Whole exome sequencing, targeted sequencing, MLPA, or a combination of whole exome sequencing and MLPA? Can we run the polls? Yes, can we have the results? Okay. Dr. Srijit, what do you think? Yes, I think majority of them have asked for a combination.
Dr. Satish, I think, is the best person to respond to that. But what we usually do is to ask for whole exome sequencing, not MLPA upfront. But yes, that will miss a lot of deletion. So, but I would like to hear Dr. Satish's view on that.
Yeah, I think I would also go for whole exome sequence rather than anything else, because you see, most likely this is an Alport-related condition, but there are other things also. It can be a C3GN type of condition, and it can be some other familial forms like the Cypriot nephropathy. There is a C5, CFHR5 variant. So these things are all possible. Multiple things are possible. Whole exome sequence. I think the combination that the MLPA is unlikely to be of much use here, because what are we looking for in MLPA? The only things which will come into this picture with copy number variants are the complement, just the CFHR1 and 3 disorders, which do not present as hematuria at all. So that would not be a target. So MLPA will not be on the primary event here. Then, having said that, I'd like to say that we have seen some Alport syndrome can present with copy number variants, but that is extremely rare.
Yeah.
So,
Even though the collagen 4 mutations are common, there are genetic conditions which are for microhematuria very rare. So that also will be picked up if you do whole exome sequencing instead of doing a targeted sequencing.
There are some other conditions like MYH1 and all that, which can present thrombocytopenia, renal failure, and they can also have hematuria. So that's why whole exome will be more important. We cannot just screen for Alport's variants unless we have strong family history of Alport's, in which case you can do a targeted sequence.
Yeah.
Okay, Jason, we'll continue, Jason. Jason will continue. Yes.
Yes. So, significance of hematuria in glomerular diseases. Hematuria is the major indicator of active glomerular inflammation and kidney involvement in various glomerular diseases like lupus, ANCA vasculitis, IgA nephropathy, and many more. So, persistent hematuria during follow-up in IgA nephropathy is associated with worse renal outcomes. Also, time average hematuria of more than 5 RBCs per high power field correlates with histological severity and independently predicts the risk of ESRD. Various studies have shown that renal survival is better with remission of hematuria, and a combination of proteinuria and hematuria has even higher risk of disease progression. In lupus nephritis, persistent hematuria independently predicted adverse renal outcomes with significantly higher risk for all-cause mortality and progression to renal failure. In ANCA-associated vasculitis, persisting hematuria after induction independently predicted kidney relapse, highlighting its value in risk stratification beyond proteinuria. The BVAS scoring also deems the presence of hematuria as a marker of active disease in ANCA vasculitis. Now, can hematuria cause AKI? Hematuria, especially gross hematuria, can cause AKI by various mechanisms like tubular obstruction by RBC CAS, direct toxic effects of heat, etc. Now, what is the pathogenesis of hematuria causing AKI? So when there is hematuria, intratubular degradation of erythrocytes occur, and hemoglobin gets into proximal tubules via the megalin-kubulin receptor system, releasing heme. Hemoglobin, heme, and iron accumulation within tubular cells triggers oxidative stress and inflammatory cytokine secretion, resulting in activation of pro-inflammatory pathways, resulting in AKI. Hematuria in pediatric population. Prevalence of hematuria is 4 to 6% in pediatric population, and glomerular disease is the most common cause of hematuria. Recent sore throat or febrile illness should raise the possibility of post-streptococcal glomerulonephritis. Just like in adults, if isolated microhematuria is present, repeat the urine analysis to exclude transient causes. If persistent hematuria is present on repeated samples, or if proteinuria is present alongside hematuria, look for features of glomerulonephritis. Do an albumin level, look for the renal function, the complement levels, etc. Basic workup like electrolytes, CBC, etc. has to be done. Look for urine calcium creatinine ratio to rule out hypercalcemia, hyperparathyroidism. Do an imaging of the kidneys with Doppler if needed. Rule out structural anomalies. Do a hemoglobin electrophoresis if family history is suggestive, or if there is suspicion of sickle cell trait or disease. Pregnancy and hematuria. So, hematuria is seen in about 20% of pregnant women. It disappears in 75% of women postpartum. Look for dysmorphic RBCs, acanthocytes, to see if the origin is glomerular. Microhematuria may be seen in preeclampsia too. And many of the times there can be unmasking of autoimmune conditions like lupus in pregnancy. Look for associated proteinuria. Look for isolated isomorphic hematuria. If it is present, it is mostly benign. With this, we come to another poll. Binu sir?
Yeah. Yeah, after hypertensive pregnancy, biopsy will be considered in the patient with microscopic hematuria if it persists beyond the postpartum period, that is 42 weeks. If it persists beyond 12 weeks, or hypertension persists after 3 months, or before the next pregnancy is planned. This is not an uncommon problem. We have also had such problems. So let's have the polls. Yes, can we have the results? Yes, Dr. Srijit, what do you think?
Most of the pregnancy-related things are expected to resolve by 3 months. So that is the general rule for most of the things. So I would go by that. I think that's what we practice also. If proteinuria RBCs persist beyond 3 months or 12 weeks is what generally, whatever is related to pregnancy is supposed to resolve within that period. So that's my answer to that.
Probably you would think of some other primarily pre-existing glomerular disease or a TMA or something of that sort. What would you consider on? What did you have in your mind when you do a biopsy at 3 months postpartum?
Beyond 3 months.
Yes.
Yeah, no, it could be anything. I will not say only about TMA. I am not sure how common is TMA to present that way. Usually, TMA during pregnancies are more virulent, I would say, but it could be anything. It could be. The primary thing is it is not preeclampsia related. So by waiting for 4 weeks, you are trying to rule out preeclampsia being the cause of the hypertension as well as the proteinuria or RBCs seen in the urine. By giving this 4 weeks, you are excluding that, and whatever remains, it could be anything. It could be IgA, it could be a glomerular disease which developed during pregnancy. It could have been pre-existent, not recognized. So by using this period, it's possible that patient had something and then had a superimposed preeclampsia. So all those preeclampsia related changes in the biopsy is expected to resolve within 4 to 12 weeks. So that is why I would wait for 4 to 12 weeks, and beyond 12 weeks is when you will pick up diseases other than pregnancy related preeclampsia or other changes.
Okay, we will wait for 3 months and then consider biopsy. Okay, Jason, can we go to the next?
Yes. Now, if you find a non-glomerular cause for hematuria, that's when a urology consult is mostly needed. So in a non-glomerular cause, you mostly find isomorphic RBCs, if at all you have access to phase contrast microscopy. So if you have ruled out a glomerular cause, the next thing to do is to do a urine culture and rule out a UTI. Get an extensive smoking history. Identify the risk factors which I've shown in this table, like age, male sex, degree of microhematuria, persistence of microhematuria, whether there is gross hematuria or not. Also look at additional risk factors for urothelial carcinoma, like lower urinary tract symptoms, frequency, urgency, risk factor, prior pelvic radiation history of cyclophosphamide use, occupation like exposure to benzene or aromatic amines, whether there's any history of chronic indwelling Foley's catheter which can irritate the bladder. So now when to advise a cystoscopy? So the American Urology Association brought out its latest amendments in 2025, and it has come up with a new risk stratification criteria. So in the past, it was recommended that whoever has a microhematuria which is of a non-glomerular origin should undergo cystoscopy. But now American Urology Association has modified its recommendations. It has classified individuals into low risk, intermediate risk, and high risk. And those who fall in the low risk need not undergo a cystoscopy. So women under 60 years and men under 40 years who are non-smokers with just 3 to 10 RBCs are classified under low risk. And these patients will not need any urgent cystoscopy, and urinalysis can just be repeated, and then they can be reclassified, and from there we can proceed. Now, those under high category are those with gross hematuria, those above the age of 60 years who are smokers, and these patients will require a cystoscopy and CT urography. What about those in the intermediate risk category? So, for those people in the intermediate risk category, the American Urology Association has brought about the idea of using urine tumor markers, about which I'll be discussing in due course. So, like I mentioned, those people in the lower risk category, we can repeat urinalysis within 6 months. Those with intermediate risk category, if the patient wishes to avoid invasive tests like cystoscopy, you can use urine-based tumor markers, and that can facilitate a decision of cystoscopy. Renal ultrasound has to be done, whereas those in higher risk category will definitely need to undergo a cystoscopy and CT urogram. Now, what are the urinary tumor markers? So the American Urology Association 2025 guidelines incorporates updated evidence on urinary markers, focusing on detecting urothelial carcinoma while reducing unnecessary invasive procedures like cystoscopy in select cases. So these are non-invasive tests detecting tumor-associated proteins, DNA alterations on mRNAs in the urine. So here you can see these are the commercial validated assays like CX bladder result, CX bladder triage, NMP22, urine cytology, Eurovision expert. These are all commercial assays. So these assays can be used in those people with intermediate risk category, but then these are not for use in higher risk patients. So and these assays are validated, so they will give us an idea whether we have to proceed with cystoscopy or not. So with this, I conclude my talk, and we move on to the last poll. Thank you.
Yes, the last question. Very often, you go about investigating microscopic hematuria, and you have a diagnosis. Still, we continue to manage this problem. So, when would you ignore and stop pursuing a case of hematuria? One, in an elderly. Second, if you find a normal biopsy, including electron microscopy, then you have a normal renal function proteinuria, even after 12 months of evaluation, or in a renal transplant situation. In which of these situations would you ignore and stop and reassure the patients at home? Let's have the polls. So I think it's a common problem. Even if you have a diagnosis, hematuria will persist. Srijit, what did you do in such situations?
So in elderly, you need to consider the possibility of urological causes. So that chance is higher in older people. And microhematuria persisting beyond 12 months is actually considered significant, so that you cannot ignore it. So my answer will be, you have done normal kidney biopsy, you have done the biopsy and EM, and then nothing is there.